All right, in this video, we're going to talk about oral contraceptives, kind of an extension of the unit we just talked about, the progesterone and estrogen. So a little background on oral contraceptives. Probably somewhere around 70 million women are in the childbearing age range, and of these women, greater than 60% practice some sort of contraception. There's lots of options. There's different devices. We're going to talk about drugs, and there's also surgery to prevent pregnancy. But we're going to spend more of our time talking about the drugs, specifically estrogen and progesterone combinations. So, the oral contraceptives or birth control pills hit the market right around 1960, a little before 1960. And before that, there weren't very many options. The only options were really abstinence or the rhythm method or, things along those lines. So with the discovery of oral contraceptives, we got a huge expansion of choices in the arena of birth control. So here's some options. We're gonna stick with just kind of talking about the hormones, but in the context of hormonal methods, we have our pills, our oral contraceptive pills, which are most of the time going to be a combination of estrogen and progestin. There's also progestin-only oral contraceptives. There's progestin injections, there's transdermal patches, which will administer hormone kind of a time-released manner over a cycle. And there's also subdermal progestin implants. So all kinds of options. We're just really going to focus on the first two, the combo oral contraceptives, estrogen, progestin, and progestin. And then, in addition to hormones, there's other types of methods. Condoms and diaphragms would be considered barrier methods. Spermicides are they sort of straddle the barrier method, as well as a non-hormonal effect. Contraceptive sponges and spermicides kind of go together. Intrauterine devices, there's different types. There is a hormone IUD that releases progestin. And we already talked about the withdrawal method, which is not a barrier. It goes under the miscellaneous category. So how you choose which type of birth control you might want, you're going to make that decision based on a whole bunch of stuff. First is efficacy. The hormonal methods are going to be by far and away the most efficacious, with almost 100% effectiveness if they are used according to instruction. Then we're going to think about adverse effects and safety. We'll talk more about that. The age of the woman, the frequency of intercourse, how easy they are to use, and that really speaks to the compliance component of this. Any pre-existing medical conditions that may limit the use of some of these methods, and then cultural beliefs and practices play a role as well for some. So this is a slide sort of illustrating the options that we just went over, or some of the options, specifically the barrier and the hormone options. So oral contraceptives, of course, are going to be taken orally. We've got injectables, we've got patches, we've got the NuvaRing, which is a device that is inserted just below the cervix. Spermicide acts as an agent that renders sperm ideally ineffective. The sponge has spermicide in it. The NuvaRing has hormone. And the IUD, there's different IUDs. There's a copper IUD that just acts as an irritant to the wall of the endometrium of the uterus. And there's also a hormone type of IUD, and then we see our progesterone mini pill. I don't exactly know why we're putting it there, since generally the mini pill is an oral administration. But there is a progestin IUD as well. All right, so let's talk about birth control pills for a minute. So most of the time, the most effective oral contraceptive is going to be a combination of a low-dose estrogen and progestin. Remember, progestin is essentially progesterone. It's a synthetic version. So the formulation of birth control pills has changed a lot from when they hit the market in the late 50s, early 60s. And basically the biggest change is the amount of hormone that is found in the pill. In terms of how these things work, we're not totally sure, but it looks as if estrogen provides negative feedback to the pituitary, and it inhibits the release of LH and FSH, which we talked about before. So essentially what's happening is we're sort of overriding ovulation, preventing ovulation. Progestin also inhibits LH and is added to stimulate withdrawal bleeding when the hormones are discontinued. So, like I said, for the most part, this is a combination estrogen and progesterone, and the formulation has changed, and there's all kinds of options. I'm just going to give you the highlights of this. You can see that originally, 40 years ago, the oral contraceptives provided 150 micrograms of estrogen. That was the dose. And now we're at, depending on the formulation, somewhere around 20 micrograms. So we were giving a lot of hormone, and some of the adverse effects, the main adverse effects, especially the death as a result of oral contraceptives, had a lot more to do with that hefty dose of estrogen. We have learned that we don't need that much to override ovulation, and subsequently have decreased the dose and have seen a decrease in the frequency of adverse effects. We also initially gave estrogen and progesterone sequentially, meaning estrogen first and then progesterone later on, kind of trying to mimic the normal menstrual cycle or hormone cycle in a female. You know, estrogen generally peaks first, followed by progesterone, which causes the estrogen to go down, and then the progesterone levels fall prior to menstruation. So this sort of sequential dosing was done to sort of mimic or create that sort of cyclical pattern of hormone. But we've learned that is not either necessary nor desirable. You're going to see this a few times on the next slide as well, and we talked about this when we talked about antibiotics, but we have to keep in mind that a lot of antibiotics and also some central nervous system agents can decrease the efficacy of the oral contraceptives. So that's good to know and to let people know of that as well. All right, so just really quickly, I just want you to have some kind of working knowledge of the different types of commonly prescribed estrogen, progestin, oral contraceptive formulations. So the options are, and it doesn't seem necessarily that one is better than the other. It kind of depends on the woman and side effects and, risk factors, etc. So the monophasic estrogens, the monophasic oral contraceptives deliver a constant. Gosh, that's every time I look at these for typos, I always miss something. So they deliver a constant dose of estrogen and progesterone through a 21-day cycle, treatment cycle. A biphasic oral contraceptive is going to keep the amount of estrogen constant, but the amount of progesterone is going to decrease towards the end of the cycle. And the idea is that allows for better nourishment of the endometrial lining. The triphasic is going to have both the amounts of estrogen and progesterone varying during 3 distinct phases during the menstrual cycle. And the four-phasic, this is the newest of these formulations, the four-phasic is going to contain synthetic estrogen, which is estradiol, and a progesterone. That Diongest is the first time we've seen that progestin. And the manufacturer claims that this formulation is going to most closely mirror a normal monthly hormone cycle. The brand of this drug, this four-phasic formulation that was introduced in 2010 was called Natazi, and that particular drug also has been approved for heavy menstrual bleeding. So, I didn't go through all the names of all these different types of drugs or formulations, but I just wanted to kind of explain to you, because you might see that monophasic, biphasic, triphasic, what that all means. In terms of efficacy, these things are oral contraceptives, and I don't know if this was on the previous slide, but they're pretty close to 100% efficacious if they are taken as recommended, which means that you remember to take them, because these are oral drugs and they have to be taken regularly. And they have to, ideally, they're taken at the same time every day. That helps also. There's one other thing I wanted to tell you about these drugs. I'm spacing out what else I wanted to say about these medications. I guess it's not that important because I can't remember. All right, let's talk about the progestin-only oral contraceptives. Again, we got to be cautious with antibiotics and central nervous system agents. That doesn't change. So these progestin-only oral contraceptives, they're a tiny little bit less efficacious. You can see their failure rate is somewhere between 1 and 4%, depending on the woman. These things are oftentimes referred to as the mini pills, which makes them sound awfully cute, but they're the big difference between these is that, one, there's no estrogen, it's only progesterone, and women are still ovulating, but what these medications are doing, due to the way they alter the endometrial lining, is they're keeping the ovum from being implanted. So they're making it so implantation can't occur. It seems to be that what they really do is, in addition to the endometrial lining changes, the other thing they seem to do is they seem to cause a very thick and viscous cervical mucus that is produced, and it blocks the entrance to the uterus, which keeps the sperm from getting in there. So it inhibits sperm penetration. And they also seem to inhibit the implantation, I mentioned that above, of the fertilized egg. Whether that's due to mucus production or other endometrial changes, we don't really know. The downside of these pills, and one of the reasons why women tend to abandon them, is there's more breakthrough bleeding, which means they tend to bleed at times independent of their menstrual cycle, and they also lead to more menstrual cycle irregularities, which that isn't a good deal. One of the main advantages to this, because there's no estrogen, if you remember, estrogen is contraindicated in lactating women. It actually shuts off lactation. So if a woman is nursing, then these and is desiring oral contraception, which is not a bad idea. That's sort of a wives' tale that says that women can't get pregnant when they're nursing. I mean, it's not that easy, but it's definitely possible. And I'm sure some of you listening may have some personal experience with that, either yourself or sort of tangentially, where somebody was a nursing woman has gotten pregnant thinking that she can't. So that is something to think about. And unless you're planning on a second pregnancy while nursing an infant, you might want to consider these progestin-only oral contraceptives. They don't seem to be as problematic as estrogen for some of those high-risk estrogen-related adverse effects. And what I'm thinking specifically here is the estrogen-dependent cancers. And they also don't seem to increase the risk of thromboembolism. So again, like I said in the beginning, you choose your contraception based on risks and benefits. And so if you're at high risk for clotting, or you're at high risk for estrogen-related adverse effects, then this would be an option. In general, the oral contraception seems to be protective against ovarian cancer and some uterine cancers, although others seem estrogen is positively indicated in other uterine cancers, so that one I would be cautious about. We see a decreased incidence in pelvic inflammatory disease with the use of oral contraceptives, although it's not a huge decrease. Also a decrease in toxic shock syndrome, and a decrease in rheumatoid arthritis and other autoimmune conditions, which is sort of interesting. Here is a slide with a whole bunch of adverse effects that are associated with a lot of different oral contraceptives, We've talked about a few of them. Cancer, of course, is a risk, especially estrogen-dependent cancers. So patients with breast cancer are most of the time encouraged not to take any oral contraception that has any estrogen. We already talked about the breast milk. They can elevate blood glucose. So if somebody got metabolic syndrome or their blood glucose is already elevated, we might want to consider that, or if they have already been diagnosed with diabetes, of course. Blood pressure can go up, especially as age increases and the patient has been on the oral contraceptives for a while. I mentioned the weight gain, fatigue, depression, acne, hirsutism. Those are all effects that seem to be compounded by progestin. So if somebody is having some of these adverse effects, you might want to switch to a different formulation that has less progesterone, keeping in mind that you can't just give unopposed estrogen, especially if the woman has a uterus, because of the effects of estrogen on the uterine lining. While oral contraceptives may have a positive effect on rheumatoid arthritis, they can exacerbate lupus, and it seems like it's the estrogen that does that. So, and it's not in all patients, it's just in some. So again, we have that option of the progestin only. That might be another reason to go that route. Menstrual irregularities, and that seems to be related to the progestin, low levels of progestin. We might need to give more. Migraines, a lot of women are sensitive to hormones, and oftentimes their migraines can be triggered right around their period, and so a woman in that camp really might have a hard time with any oral contraception, including and definitely estrogen. Nausea, edema, breast tenderness is, again, high amounts of estrogen can cause that. Progesterone can to some degree as well. Estrogens are not to be given to pregnant women. It's a pregnancy category X. And then, of course, we mentioned the blood clots already. So we don't want to give any oral contraceptives containing estrogen to women that have a history of clotting disorders, that have already had a stroke, that have coronary artery disease, or if they're smokers. All of those will increase the risk of clotting. So I want to flip gears for a second and talk about emergency contraception, which is just another form of contraception, but not traditionally recommended as your primary and only birth control method. So these formulations oftentimes are referred to as the morning after pills. And it's not a great name because you have a larger window of opportunity to take these and still have them be effective, although the efficacy will decrease the further away you are from the unprotected intercourse and or contraceptive failure. So what I want to say here is, if you use these drugs right, they are not causing an abortion, right? What they're doing is they're inhibiting implantation. So if the fertilized egg is never implanted, then we don't consider that pregnancy ever being viable. So one of these drugs that you may have heard of is called Plan B, or I should say one of these formulations. Plan B has now been approved as an over-the-counter purchase for women that are older than 17 years. If they're younger than 17 years, they are going to need a prescription. Basically, what Plan B does, and these emergency contraceptives have in them, is they have a hefty dose of progesterone. So you can see a very large dose, 1,500 micrograms or 150 milligrams. Traditionally, in a monthly cycle, in a monthly formulation of oral contraceptives, if I'm remembering correctly, the amount of progesterone is like in the 20 milligram category. And so this is a heavy, heavy, heavy dose of progestin. I'm going to consult my notes for a second to make sure I have that right. Yeah, so sorry. So I was looking at one of the progestin-only formulations. Sorry, it's 20 micrograms per day of progesterone. And that's one of the kind of slow release progestins that is in the progesterone IUD. So it's in there for a long time. So essentially what that Mirena is called releases 20 micrograms of progestin over a 5-year period, per day, I should say, over a 5-year period, where Plan B delivers a total of 1,500 micrograms in one single day. So that's a pretty hefty dose. And so let me flip here and I'll show you. So here's how you do here's the two most popular, I should say, there's two Plan B formulations. There's Plan B and there's Plan B one step. Plan B is essentially 2 tablets of 75 micrograms of progestin. The first dose within 72 hours of unprotected intercourse, and the second dose will follow. Sorry, the spell check. It doesn't work when the words are spelled correctly, but just don't make any sense. And the second dose follows 12 hours later. So your first dose within 72 hours, ideally closer to the unprotected intercourse and or contraceptive failure earlier, the better. The closer you are to the event, the better in terms of efficacy. Then we have the Plan B one step, which is just 1 tablet, which is the same amount of progestin within 120 hours of unprotected intercourse or oral contraceptive failure. So the big difference is there are going to be side effects. You're going to have more side effects with that hefty dose, but it's not going to probably be significantly more. So I guess one of the ways, at least one of the ways that I think about this is if somebody misses that 72-hour window, but they still want to go this route, then the Plan B one step would be the option. I probably would recommend, if you're within the 72-hour window, to go with the Plan B, the regular Plan B, because it's just going to be, like I said, it's going to be a little less uncomfortable. Although you're going to have side effects either way of a lot of progesterone. There's another drug called ulipristal, which is a 130 milligram tablet within 5 days of intercourse. So again, that's milligrams, not micrograms. So that would be 3,000 micrograms. It's a lot of progesterone. In terms of how these morning after contraceptives work, they're going to delay ovulation. They're going to inhibit fertilization. That's the big one because they've more likely already ovulated. And they might possibly also inhibit the tubal transport to the endometrium. There's other ways to go about this, and before Plan B, you could read it up. I have a book called Contraceptive Technology, which has everything you could ever imagine, and then some about oral contraception and otherwise. And so you could take, certain of the oral contraceptives. If you had the whole pack, you dial it in and try to approximate the doses that you're going to need to inhibit implantation. And so that's what some of these other recommendations are. Previn and Overal are both oral contraceptives. You can see another. DES, diethylstilbestrol, this is unlabeled use for DES, and DES has its own inherent risks, but this is a possibility. You can take it twice a day for up to 5 days after the unprotected sex and or failed oral contraception. Okay, so finally, so now we're switching gears. We're going to talk a little bit about a drug that was formerly called RU486, but it is called mifepristone. It's approved for endometriosis, fibroid tumors, breast cancers, benign brain tumors, but it can be used to abort a pregnancy if the pregnancy is less than 9 weeks gestation. So this is not an oral contraceptive, right? This is going to promote an abortion. This is after there has been fertilization and implantation. And the way that this particular drug is used is it's administered as a single dose within that window. And again, there's more to this, of course. There needs to be evaluation. They need to know confirm the pregnancy and confirm that the pregnancy is less than 9 weeks gestation. The success is going to be better and the risk is going to be lessened if you're on the closer end towards fertilization, closer in towards conception. So a single dose of mifepristone is administered, followed by a single dose of another drug called misoprostol, or I think the brand name of that is Cytotec, if I remember correctly. Yeah, Cytotec. So that Cytotec dose follows the single dose of mifepristone 36 to 48 hours later. So what mifepristone is it's a synthetic steroid that blocks the progesterone receptors in the uterus. And if you give it in that window prior to 9 weeks gestation or 9 weeks post-conception, it will abort the implanted embryo. The main and very common adverse effect is going to be a lot of cramping and nausea. It's very common, and prolonged bleeding. And that bleeding it's not uncommon for that bleeding to continue for a week or two after dosing, and the cramping can persist for quite a long time as well. There's inherent risks in this. One is that it's not effective, or it's only partially effective, and the potential for infection post miscarriage is pretty good. So there needs to be a lot of monitoring in this situation. And again, I can't emphasize enough that this is not the same thing as a Plan B or a morning after contraception. This is not emergency contraceptive. This is not a contraceptive at all, and shouldn't be treated as if it is one under any circumstances. All right, so hopefully that cleared up a little bit, or at least introduces you to the concept of oral contraception and what it's all about, and sort of what some of the options are. There's a lot of these options, and like I said, and a lot of people using them. So the efficacy is good. The kind of rewinding back to the combo or estrogen progestins, those are by far and away the most efficacious and the most commonly used. But you have to kind of think about the risks, the benefits, and any potential factors that would either decrease the efficacy or increase the risks and or side effects. All right, so that's this one. We will come back with bone density. That will be the next video. See you then.